cover the next talk as well, which is managing post-op refractive surprises. This is again very important in giving your cataract patients 6/6 vision. So first you need to know why there is a refractive surprise. Sorry, just going into the slideshow there. Yeah. So first you need to go back and check why you've had the post-op refractive surprise. So recheck the biometry and see if you have used the correct IOL formulae. Make sure that you correct all cylinders either by a toric lens or by limbal relaxing incisions. Make sure that it's the right patient and the right eye. These errors can happen. Human errors, data entry errors, transcription errors can occur. Make sure that this hasn't happened. For the possible causes for minus residual refractive errors are adjustments for sulcus IOLs. If you've placed the lens in the sulcus and not made an adjustment for the lens power, this can happen. Back distension syndrome, where the IOL is rotated in the bag or it sits a little anteriorly in the bag. Capsular contraction syndrome, all of these cause minus residual refractive errors, and the plus errors are mainly post-refractive surgery and are more common with plate haptic lenses. So this was already discussed by Dr. Gaurav. I'm going to skip this slide. So what are the management options for post-op refractive error? There's a non-surgical management. Yes, you can always give your patient spectacles or contact lenses, but the reason they've come to you is because they want to be spectacle-free after your cataract surgery. So your surgical options can either be cornea-based or lens-based. Cornea-based, of course, PRK, LASIK, SMILE. You can do an ablation or a lenticule procedure and remove the residual refractive error from the cornea. Of course, we need to wait for 3 months before we do these procedures. Lens-based options are if there is a rotated toric IOL, re-rotation of that IOL itself corrects the cylinder. Piggyback IOLs on top of the primary IOL is an option. Piggyback ICL on top of the primary IOL, IOL exchange, and optic capture, which we'll discuss. So coming to cornea-based procedures, this is the choice when the residual refractive error is less than 2 diopters. There's no corneal pathology or significant dry eye, no glare, halos, other photic phenomenon. And how long do you wait? For PRK, once the manifest refraction is stable. For LASIK, at least 3 months after the initial surgery until the refraction stabilizes. Now coming to the lens-based procedures, the iTrace has a very nifty tool which tells you how much the rotation has, how much of the rotation of the toric IOL has happened. And here it tells you how much rotation and how much change in cylindrical power will occur when you rotate it by 19 degrees. So this is an easy tool. Of course, you can always check on your slit lamp itself the intended axis and see if there's a gross rotation. Now coming to secondary piggyback lenses. When you decide to implant a piggyback, of course, implanting a piggyback lens is much easier than explanting the IOL and re-implantation of a new IOL, especially when the cataract surgery has been done a few years back or more than 6 months when the capsule has become adherent to the bag. Now this is an axial length independent calculation. It's based on careful manifest refraction, and for hyperopic errors up to 7 diopters, the spherical equivalent is multiplied by 1.5, and for hyperopic errors beyond 7 diopters, Holiday R formula or refractive divergence formula can be used. Now this is just a way to calculate the power of your piggyback lens. So it's not an axial length based calculation. So for hyperopes, for short eyes, these are the formulae. I won't go into the details. This is the slide. Again, for hyperopes and myopes, that is overpowered pseudophakic or underpowered pseudophakic, the calculation is slightly different. Now, coming to which lens to use. Of course, Rayner has their Sulcoflex lens, which is especially designed to be used as a piggyback lens. 3P silicone IOLs can also be used, or the Star ICL can also be used as a piggyback lens. Coming to the Sulcoflex lens, is a single-piece hydrophilic acrylic IOL with a 6.5 mm optic and 13.5 mm overall length. It has a round edge and concave posterior surface, convex anterior surface, and the thickness is of the optic is about 0.25 to 0.75 mm. It has an angulation to sit nicely in the sulcus. So the haptic optic has an angulation to fit into the sulcus of about 10 degrees. Now, of course, polypseudophakia does have its own complications. You can have pigment dispersion, pigment between the IOLs, iris transillumination defects, uveitis, secondary glaucoma, etc. And these are the stages of the interlenticular opacification. Now, I just want to show a couple of cases where postoperative refractive surprises were managed. This is one of the first cases. Here, you can see that there is quite a bit of adhesions and fibrosis between the lenses. This is a post-RK case after which there was a residual refractive error. Here, what the surgeon is doing is making a posterior capsulotomy for the posterior capsular opacification, after which a Rayner Sulcoflex lens is implanted in the eye. So this patient had undergone RK in both eyes, after which the IOL was implanted and had a PCO as well. Now in this patient, actually a mini monovision effect was achieved just by implanting the Sulcoflex lenses as a piggyback lens. Peripheral iridotomy was done, and this is how the lenses sit in a piggyback situation. This is an OCT, and post-operatively you can see that the right eye had better near vision and the left eye had better distance vision, and the patient binocularly was seeing 6/6 and N6, which is an excellent result for a post-RK eye with a piggyback lens. Coming to IOL exchange, just a couple of videos. There are a few ways to do an IOL exchange. Again, this was a young patient implanted with a trifocal lens, which they were extremely unhappy with due to a lot of dysphotopsia. So it was decided to explant the lens and implant another lens in its place, another trifocal lens in its place. So this set of instruments is very useful. It's the grasping forceps and the IOL cutting forceps available with MST. So it's cut 3/4 of the way, and the incision is extended a little bit. One half of the IOL is pulled out of the incision and rotated out so that the entire lens comes out easily. This is the standard technique that we use. Of course, it's important to have the right set of instruments. This set of MST forceps really helps with this IOL implantation. LRIs were also done with femto to get a good result. Now coming to explantation of plate haptic lenses, this is slightly different. Then I'm just going to fast forward this video. You can see that the lens kept rotating in the bag. So this is a high myope with a plate haptic lens in the bag. Rotation was done multiple times. You can see the IntelliAxis nubs there, and the IOL is just not sitting in place. It keeps rotating, and this lens was cut in half and explanted because it's easier to explant the plate haptic lenses this way. The same set of MST instruments were used to do this explantation. The IOL needs to be grasped tightly, and it's important to inject viscoelastic under the IOL so that you don't touch the posterior capsule while cutting the lens. This lens, a bimanual technique was used to remove this lens, and another trifocal lens was implanted. A C-loop haptic trifocal lens was implanted in its place. Okay. Moving on to the next case. I'm just going to fast forward this video for the paucity of time. It's very important when there's adhesions to use a thin iris repositor to actually dissect out all the adhesions, remove the lens, and again, like I said, you can bisect the IOL completely and remove one half after the other through the incision. And here you can see what happens while removing one half, that there is a pull and a tug on the capsule, and there's a ZD there. This is a Nightingale polisher which is used to polish the PC and clean off all the PCO there. And a CTR is used. So it can be quite tricky once the bag collapses on the lens and adheres to the lens. So this is a bimanual technique of CTR insertion. And once the lens is implanted after this, you can see that it's well centered. The last case that I'd like to show is a case scenario of a 54-year-old female ophthalmologist who came for an opinion for refractive correction. She had a -6 in the right eye, -7, both eyes with a cylinder. You can see here that she's unsuitable for refractive surgery because the cornea was very borderline, and the anterior chamber depth was also 2.32, so she was unsuitable for a toric ICL. So the surgical plan was to do a femto-assisted refractive lens exchange for this patient with implantation of a trifocal lens and arcuate incisions. So 3 weeks post-op, she came back with a residual refraction, and she had a -1 residue in the right eye and with both eyes 0.5 cylinder. So you can see that the lens here is sitting quite anteriorly, and this was how it was managed. So the same old incision was opened up, after which the IOL was moved, and here you see that the adhesions are very carefully dissected using a visco dissection technique, and the IOL is slowly lifted up. A side port incision is made, and using a cystitome, a posterior capsulorhexis is made under the IOL. So after making the initial nick, sodium hyaluronate is injected to push down the vitreous. And you can see here very carefully a posterior capsulotomy being done using a microrhexis forceps. The reason the posterior capsulotomy is being done is to try and capture the IOL in the posterior capsulotomy and push it backwards so that it negates the myopia. So I'm just showing you how that optic capture was done. It's pushed into that posterior capsulorhexis, and the lens is stable and well centered. The viscoelastic is removed, and this is the post-op image. Post-operatively, she had 6x6 parts. The lens is stable and well centered in the right eye, and in the left eye it was the same residual refractive error. So a 0.5 cylinder is still manageable, and the patient was very happy post-operatively, and this was the clinical picture. So this was a very unusual management of a residual refractive error. And just some take-home messages: prevention of a residual refractive error is key. Please communicate with the patient and have an algorithm for management. Unconventional options can work very well too. Thank you very much.
Thank you, Dr. Supriya, for two extensive talks. And I think while Dr. Sheetal is just getting set up, why not bioptics? Why the posterior capture for that patient? Just to show a different technique, or is there any additional purpose that you feel that is?
Bioptics was not possible because this patient was not suitable for either an ICL or a corneal refractive surgery. Patient had a very borderline cornea, and the AC depth was 2.32, so we couldn't even put an ICL or any other lens there. So this was an unconventional way to manage it. It was carefully done, probably not very predictable, not a very predictable way to do it. Patient was very clearly explained the surgical plan as well, because she was an ophthalmologist herself. So she was ready for it, and it was done.